Welcome, dear friends. This is Dr. Sharad Jaitly from New York. I'm here on your favorite website, MuniMeterHealth.com, which is there dedicated to teach you, educate you on human heart and its illnesses, and gives you the free knowledge to know both from the fraternity group as well as the general community group regarding the management of the heart conditions that we commonly encounter. So once again, I thank you for your interest, your enthusiastic support in associating with MuniMeterHealth.com, which is your favorite website, I know, dedicated to teaching you cardiology. So without any further ado, I like to delve into the state of the matter today, and the state of the matter, the subject being infective endocarditis. Now, this is a very, very important subject which we come across specifically not only within the tropical countries, but also within the temperate countries, I should say, where a lot of prosthetic valves are happening, and intravenous drug abuse is still prevalent, and there's a lot of endemic foci of certain infections ongoing. So one has to be a little more cognizant. So let's understand what is, by definition, what is infective endocarditis. Well, one, you have to demonstrate a fever which is lasting more than 2 weeks. Two, you have to define if there's a changing murmur. If there's a change in a murmur or it's a new murmur. If it's a new murmur, then obviously this could lend more support to the diagnosis. And then you have other signs and symptoms where patient has weight loss, malaise, and then of course anorexia. These are minor criteria. But then splenomegaly could be one of the physical findings. Obviously, you'll hear the heart murmurs, and patient may be developing heart failure, etc., etc. So these are common symptoms. And then you have peripheral symptoms and signs where, commonly it's written in the textbooks and in the articles, and definitely it'll be on the boards for the people who are training and getting into the boards, etc. So just remember, there are Janeway lesions, which are painful. They're painless lesions within the pulp of your palms, and then you have the Roth spots, which are the retinal hemorrhages that occur commonly in the setting of infective endocarditis. And then there are osselar nodes. These are just eponyms that you may want to remember. And the osselar nodes are very painful, but none of them, they are pathognomonic. So what is pathognomonic is, or what is the diagnostic criteria for infective endocarditis is you have to demonstrate a blood culture which is positive for organisms. So you have to demonstrate that there is a bacteremia, or there is some level of septicemia ongoing, whether it's bacteremia, fungemia, etc., whatever the atypical organism that's growing, you have to demonstrate that. And then last but not the least, you should be able to say, is there a vegetation that you see on an echo? So these two tests are very, very important in addition to the clinical part, blood cultures and echo. And on the echo, obviously, you're going to see a vegetation. Now, a lot of people worry about what is a vegetation, so let's define that first. A vegetation is an amorphous material that is collected on the endocardial surface of the valves or within the endocardium, the mural endocardium itself. It's an amorphous material, as I said, and it consists of platelets. It may consist of fibrins and some macrophages. Obviously, macrophages are engulfing white cells with a lot of microbes which are dead or alive, and or inflammatory cells as well. So it's an amorphous material which consists of all of this, and microscopically obviously. But the vegetations, now let's draw the heart here for a second, so this way you have a better idea what we are talking about. So here's my favorite cartoon, if you will. And you have the tricuspid valve here. Obviously, we're going to show 3 leaflets as always. This is your mitral valve. This is your left side, and here becomes your aorta, and this is your pulmonary artery, for instance. And this is the right side. So this being the right and this being the left, you're looking at the 2 atria and the ventricles, and then the valve vegetations will be sitting on the undersurfaces of the mitral valve or within the aortic valve, if you will. In the tricuspid valve, in the setting when you have a right-sided endocarditis. So the whole phenomenon is related to, one, which valve is involved and under which setting. So let's understand quickly within the scope of this video, because I do want to have you grasp what best I can really offer you within the scope. So we have native valve endocarditis, and we have prosthetic valve endocarditis, where the prosthetic valve is already in place. And then you have the right-sided heart, the right-sided, I call it, right-sided heart endocarditis. And then the left-sided is predominantly mostly on the left side, let me talk about. But the right-sided endocarditis is predominantly either health-related, which is iatrogenic, where somebody just had a procedure done, like a CVP lines placed or arterial lines placed. So I call it healthcare related. And the other one is IV drug abuse. So patients who use IV drug abuse, the prevalence is very high, and the right-sided endocarditis in them, specifically the tricuspid valves, etc., will be ascertained in those individuals, because the vegetations will develop on these valves on the undersurfaces, and if you will. Now, some of these vegetations, by the way, they can grow rather big and growing, and sometimes vegetations may not disappear. For instance, you can have a vegetation that can be chronically there and the patient readmits for some other reason, like say pneumonia. And now you demonstrate a bacterial infection on a blood culture here. Then at that point, that vegetation which was there 5 years ago or 10 years ago, previous history of endocarditis was known, or the patient manifests during the history taking, does not imply that the patient is having endocarditis again. But the fact is that if the endocarditis has grown in size, in other words, the vegetation, new vegetations or growing vegetations, or even changing heart murmurs or new, so those things will imply that the patient is having another episode of endocarditis, and it could be a relapse, in other words, a recurrence. So, there's a lot of data out there in the textbooks and the articles, and I want you to supplement that. But within the scope of this video, I just want to make sure that we get the salient points in. Now, native valve endocarditis here, the commonest organism obviously is Staph aureus. Strep viridans. And the prosthetic valve, it is the Staph aureus. Okay, so just remember that. So you have the Staph aureus here, and you have Strep viridans for the native valve endocarditis. Now, which is more common than the staph, and which is more common than the enterococci, if you will. And this, we are talking about the native valve, like the aortic valve and the mitral valve. But if you have the prosthetic valve endocarditis, the Staph aureus is the lead in the team. And second to that will be the enterococci, and then diphtheroids and HACCP group of organisms will come in. Now, what is a HACCP group of organisms? Now, this is an entity which has been defined, for decades now, and one should be cognizant. This will be definitely on the boards. If there's one or two questions in infective endocarditis, one they could be related to the HACCP group of organisms. So let's define what HACCP is. HACCP is H for Haemophilus species, A for Actinobacillus species, C for Cardiobacterium species, Eikenella for E, and Kingella for K. So HACCP group of organisms, they are very fastidious. They are very slow-growing organisms. On blood cultures, takes more than 5 days, sometimes weeks. So invariably, the patient's labs will be showing no cultures grown. But you have to still worry about it. You have a vegetation, you have a blood culture which is positive, you have the clinical features which are already there, and patients responding on the antibiotics. Consider HACCP group of organisms, guys, because you have to make sure that these take forever to grow sometimes. So just remember that. Sometimes the patients get discharged and then the cultures come back. So that could be a possibility. And then atypical bacteria are very, very common also in these prosthetic valves, like the diphtheroids. And do not forget fungi. Now, fungi really goes higher on the list with the prosthetic valves, even though with what you call native valve endocarditis, it may be way down, like less than 3%. But in the fungal infections in prosthetic valves are very, very high. They could be up to 10 or 15% of the entire prosthetic valve endocarditis incidence or prevalence. Right-sided endocarditis is, as I said, either in IV drug abusers or in healthcare related, and the commonest, obviously, it's a no-brainer, and you have Staph aureus there as the common one, because obviously unclean needles are being used by the drug abusers in a setting where they are addicted to the drugs and they are using these needles. They're not, sometimes they are exchanging needles between the partners and what have you. Healthcare related endocarditis will again imply that maybe, as I said, CVP lines have been inserted and patients get discharged, got better, or they are still in critical care ICU settings where arterial lines are there and they've not been changed, or they have been changed, but then still, you know, these iatrogenic infections can travel via the veins or via the arteries and then lodge into the right side of the heart. So Staph aureus is the leader there as well. Having defined these, let's understand quickly where, you know, we'll shift the gears a little bit and quickly say where would you want to use surgery as an option. Now, so when is surgery indicated? Let's delve on that fact first. The surgery in infective endocarditis is indicated in certain individuals only, and one of the groups I should always say is where you have prosthetic valve endocarditis, which is specifically if it is a staph or a fungi. Invariably, they will require surgery. Remember, staph and a fungi will definitely require prosthetic valve, and patients who have relapsing endocarditis, like patient who had a endocarditis which was treated with antimicrobial therapy and you felt everything is good, patient's discharged, comes back 6 months later with another episode of the same valve involvement, and now you have another valve endocarditis there with a new vegetation or a growing vegetation. That's considered quote-unquote relapsing endocarditis, and therefore you should consider surgical replacement because that valve is permanently damaged. It's not going to heal, and those vegetations got to come out. A third variety, it's a relative indication, but still is, most authors, they believe that if you have a 10 millimeter and above, if you have a vegetation which is almost obstructing the mitral valve, for instance, or if it's a 10 millimeter and above vegetation which is sitting here and partially obstructing the mitral or the aortic valve, that should be operated. So more than 10 millimeters in size. Again, the character, the size, and the, you know, the extent and the valve location, all those, there are numerous data is available, but then predominantly it's the mitral and the aortic valves where the vegetation is more than 10 millimeters. That's the cutoff, I think. And on the boards, I think they'll give you a question. If there's a vegetation they want to operate, have that operated, they will definitely show you somewhere 10 millimeters in that question. So just to keep an eye on that question right there. All right. And then, of course, a fastidious group of organisms which are very difficult to treat many times, specifically if they are growing within the prosthetic valves. Fungal, I already talked to you about. Do not forget the previously known congenital heart disease in these patients. Oops, my board just moved a little bit, and I'm going to get that back. It's the opposite way. Yeah. Okay, so congenital valves, which are very, very important in these settings, and you will see that growing. So you have a congenital heart disease. And then like an ASD repaired or ASD repaired with a patch or a device. Again, they're highly prone for infections, then they will not be amenable to antimicrobial therapy. You're better off giving them surgery as an option, okay? Cardiac transplants. So remember cardiac transplants, that's the other indication where one would have a patient operated upon, either the valve which is infected or the surface that's infected, the endocardial myocardium, etc., or any patch or device that has been replaced. So you may want to reconsider that constructive surgery in that cardiac transplanted patient. Corrected cyanotic heart disease with devices should also be taken into an account. So these are some of the areas where one sees. And in the native variety, I would say specifically the Staph aureus. Now, a lot of authors, at least, they feel that about 50, it's like a 50-50 here. I would say a 50% improvement with antimicrobial therapy, and the other 50% do not improve. They go for valve replacement. So native valve endocarditis with a Staph aureus infection is a big iffy still, and we don't know whether they should be operated across the board. But in general, most authors will feel that if there is a resistance there to the organism being treated, so you'll be better off treating them. And last but not the least, where you do not have the antimicrobial therapy available, or sometimes it's not effective. If it's not effective and it's not available, then you end up using surgery as an option, because then there's no other choice. Like if you have, say, a HACCP group of organisms or dithroids, or very, very atypical, or it's a culture negative endocarditis with significant valve infections, you are better off using a surgery as an option and have them treated. Okay, I thank you again for this, little video vignette interaction with me, and stay tuned for more intricate stuff in cardiology coming down the tubes. I'm so excited that you're on Facebook and YouTube, and hopefully on both of them, so this way you can use one backing the other. should one app is not working. But I just want to be thankful again and acknowledge your interest and enthusiastic support that's growing across the globe now between the interns, the residents, the fellows, the colleagues, and my dear friends. Thank you so much for watching Infective Endocarditis today on MuniMeterHealth.com. This is Dr. Sharad Jaitly. So long.